Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is colorectal cancer, and our guest is Dr. Mayin Lin, colorectal surgeon at the MercyOne Cancer Center.
Thanks for having me, Dr.
Thank you
Deming.
for being here. And before we start talking about colorectal cancer and prevention and detection and treatment, let's learn a little bit about you. So where are you from originally?
I was born in Taiwan, came to America when I was about 2.5 years old.
Oh,
So
wow.
I've known nothing more than, American life. Raised in Los Angeles, California,
Okay.
sunny California. Went to school there, did my undergraduate there.
How big of a high school did you go to?
I went to a very large high school. It was our graduating class was probably 800
Oh,
people
wow.
in our senior class.
And
Yeah.
what was was it Los Angeles or was it a different one of the suburbs? Or
It
what?
was a suburb of Los Angeles named Arcadia, California.
Arcadia.
Yep.
800 in your
800
class.
people.
What
Yep.
was your claim to fame in high school?
Oh gosh, I think I was a speech and debate nerd. So
Oh, were you?
yep.
I was too.
Oh really? My
Yes.
favorite. I did dramatic reenactments and
Dramatic interp?
Yes, exactly. Yep.
Okay, so what piece in high school dramatic interp
Oh gosh.
are you most proud of?
I couldn't remember. I've done so many. I think I'd lost count. So I think just every piece was different and exciting to me. So
And then did you do theater as well?
I did not do theater,
Okay.
no. But I've always been more inclined towards the humanities growing up.
Mhm.
So yeah.
And then undergrad was where?
I did undergraduate at UCLA.
Okay.
Yep, in Los Angeles as well.
Definitely a
Yep.
Los Angeles person.
Yep.
I did not realize that. And what was your first declared major when you started UCLA?
I was an English major when I went into college. I wanted to be a writer. I wanted to write adolescent coming of age novels. That was my goal and the way I was going to change the world.
And when did that switch?
I think sometime probably during my first going on to second year, I did a seminar, one of those after dinner seminars that UCLA offered, and it was all about the Human Genome Project, and I got really excited about it. Something about being able to sequence the entire human genome and solve all diseases known to mankind was very inspiring to me. So I switched to molecular bio. I not switched. I still kept my English, but graduated with a minor instead.
Wow. And so you clearly knew from high school and college that you had an aptitude for math and science.
I think I did better in the humanities actually. But yes, I did fine in the science classes. And in high school, it didn't quite inspire me as much as the imaginative part of being in English and learning those courses.
So then where did you go to medical school?
I ended up, before medical school, I actually did a master's in public health and then worked on that during my master's in public health. Worked at a mobile testing unit, and there I got to know quite a few physicians that really inspired me with their one-on-one relationships with patients. And so then I went to medical school at Western University in Los Angeles. It's the osteopathic school.
Okay. And then during medical school, so in medical school, I liked everything. And every rotation I did, I sort of saw myself as being that sort of a doctor. What was your experience and how did you gravitate towards surgery?
I was pretty sure going into the clinical year. So in medical school, I went to the traditional 2 years of classroom and then 2 years of clinical work after that. And so going into the clinical years, I had my mind set on psychiatry. Actually, I was pretty sure I wanted to do that. So I set up my rotations in a way where I'm definitely a bad news first type person. When I was a child, I ate my peas and broccoli, and I saved my French fries for the the very end because I wanted to savor every bite. So I did actually surgery first. And that just, gosh, I will never forget the first case I scrubbed into. And it was one of those, I never really believed in one of those life-changing moments, prior to this. But I definitely could not shake surgery from my mind for the rest of that year. And I couldn't stop thinking about surgery and
Do
the
you remember what the case was?
Yes, it was a case of a lady who was very sick from C. diff colitis, where your entire colon gets pretty sick from overgrowth of bad bacteria. We have a lot of good bacteria in our gut, but the bad bacteria kind of takes over, and she needed her entire colon out. And I just remember that visceral, just tangible case where we took the colon out and we could feel it, we could touch it, and she just turned the corner, and the next day sitting up talking to us, sipping on water. And it was just such a drastic difference that really
Wow.
impacted me.
So the training to become a colorectal surgeon, first there's general surgery.
Yes.
And where did you do your general surgery residency?
I did a few years of general surgery residency right here in Des Moines at MercyOne Medical Center.
Oh.
Yep. Due to some circumstances, I ended up finishing my training in New York in a pretty large urban center at New York Presbyterian in Queens, and then went on to do my fellowship training, and then ended up back here because I loved
Okay.
Mercy so much.
So general surgery is
Yes.
like 5 years.
It is 5 years.
And
Yep.
then to become a colorectal surgeon, you have another 2 years after?
1 year.
1 year.
Yep.
And when during your 5 years of general surgery residency did you decide that you wanted to then subspecialize in surgery of colon and rectum?
So I really enjoyed apparently plumbing because I initially wanted to do vascular surgery. So I knew I wanted to work with the pipes. I just didn't know which type of pipes, which set I wanted to work on.
The blood pipes, the urine pipes, or the stool?
Or the stool pipe. So I initially wanted to do vascular surgery. Just the surgeries itself technically were very just delicate, just like a ballet. Just the choreography of that is just beautiful. Then I realized with the disease process of colorectal surgery was what really had my heart. Colorectal surgery is made up of 6 overall pillars, and they are the anal rectal pillar, benign disease, malignant disease, which we'll be talking a little bit more about today, pelvic floor. So pelvic floor, for example, things like fecal incontinence, constipation. So everything from you don't move enough to everything, moves too much. And then endoscopy, which is doing colonoscopies. So it was such a diverse range of diseases that you get to work with, and then also a diverse range of people. Vascular patients were a little bit older typically when they have vascular disease, but my youngest patient I have seen recently is 16, and my oldest that I've ever operated on was 94. So he's still doing well today. So that's that part of colorectal surgery, the disease processes and just the wide range of people you get to work with really attracted me.
So you're talking about the range of diseases. We're going to talk about colorectal cancer, and just in our lifetime, in fact, in our professional lifetime, we're seeing the age at which colorectal cancer patients present much, much younger. In fact, it used to be that we didn't recommend screening till age 50, but we're seeing so many patients with colon cancer or rectal cancer at a younger age that the national guidelines for screening has decreased. Just this week, I saw a gentleman who's 31 with colon cancer. So.
Yep, that's definitely a alarming trend that we've been seeing over the last 10 years. And part of it was, we were doing such a good job with screening those who are older. The previous guidelines were 50. It's now 45 and younger. That we're seeing a decrease in the trend of patients who are being diagnosed with later stage colon cancer because we were doing such a good job with screening, and that in juxtaposition with the alarming rise in the trend of younger patients. And we define that as younger than 45 years old.
Okay.
And it's because we don't screen those younger
Mhm.
patients.
What do you think the cause of this younger population in colorectal cancer? Do you think there's a different fundamental pathophysiology? Is it different risk factors?
Mhm.
What do you think is contributing to us seeing more colorectal cancers at a younger age?
There's been a lot of different theories on that. I think the most accepted theory at this time is somewhere in the 1970s, just from an epidemiologic, when you look at the big population type view, we saw a change in the diet as well as heavily processed foods, increasing a sedentary lifestyle, just, with our advances in our technology and things like that. I think sedentary lifestyle, childhood obesity started to rise at that time as well. So those were all trends that started around the 70s. And then a few decades later, we started to see this rise in the incidence of young onset colorectal cancer. And
So
they think maybe.
primarily diet, and then how that leads to metabolic syndrome and
Mhm.
obesity, and that sort of triad of
Yes.
inactivity, nutrition, obesity.
Yes. And certainly there's the genetic factor to that as well. But overwhelmingly, the patients who are being diagnosed younger, it's not majority due to genetics, actually, that we're
Mhm.
seeing. So.
So one thing, it was just in the news today, so there's going to be national guidelines on PFAS. So PFAS is chemical additives that are often used to make clothing or cookware water resistant or stain resistant. And there's thousands of them, but now there's going to be 6 that we're going to have to check our water supply, and that some of those PFAS chemicals
Mhm.
have been linked to cancer, and some ag chemicals are
Mhm.
linked to cancer. I wonder whether there's any, as all of us in the United States are exposed to more chemicals as we become, centered on plastics and synthetics and chemicals that permeate every aspect of our life, whether we'll
Yeah.
ever see a relationship with some of the chemicals to these earlier cancers.
Well, perhaps. And, Dr. Deming, they were also pointing towards, in a similar vein, antibiotics, increasing
Yeah.
use of antibiotics, very similar to, us seeing all these chemicals in our environment. Starting in the 70s and 80s, we started really increasing our use of antibiotics as we had
Yes.
such sophisticated ones to treat the diseases that, and so that's, was linked to increasing risk of cancer as well.
Yeah, because as you pointed out, we've got lots of bacteria in our body,
Yes.
and many of them, if not most of them, are in the gut, and most of the bacteria. I mean, I've heard at some point we've got like twice as many microorganisms in our body as we have human cells,
Mhm. Yes.
and that in the gut, the vast majority of those are healthy,
Yes.
positive, and interact in many different ways. And antibiotics, unfortunately, don't just kill the bad bacteria, but kill the good bacteria, and that perhaps changing the whole microbiome of our body, meaning all of the microorganisms, that can't always be good and sometimes has consequences.
Yes, I think the gut is a very special organ in our body because it comes into direct contact. It's one of our inner organs, but it has direct contact with everything we eat and our environment. And so if you think about it, everything you put into your mouth comes in direct contact with that mucosal lining, which is the inner lining of your pipes. And so that makes for a very interesting milieu of environment.
So, because you're an English major,
Mhm.
I'm going to ask you to riff on this concept of gut instinct.
Mhm.
When did people first start using that phrase? And knowing what we know now about how the gut might actually affect psychology, maybe even philosophy, this relationship we're learning more and more, whether it's through the nervous system and vagus nerve, or whether it's through microbiome. What do you think now, as a colorectal surgeon, when you hear the concept gut instinct?
So, because of the English portion of me, I will just say that gut instinct to me initially meant I ate something too spicy, and my gut instinct is not to eat that again. But the gut brain relationship is very interesting, and certainly there have been a lot of postulates about whether or not there is a axis. They call it the brain gut axis, and there's a lot of studies being done on that right now. And I definitely think that they're related.
Mhm.
Mhm.
Good. So we're going to now shift to focus on colorectal cancer.
Mhm.
So maybe start off even why we say colorectal. So what's the colon and what's the rectum, and maybe compare and contrast colon cancer with rectal cancer.
So, the colon is the part of your guts that starts from your small intestine all the way to what we say the rectum. And the rectum is about the last 15 centimeters of your gut, right before where things get eliminated.
So about the last 6 inches
That's right.
is the rectum, and the large intestine above that is the colon.
Yes.
And how would you compare and contrast a colon cancer from a rectal cancer?
So, colon cancer is treated quite differently from rectal cancer, and part of that is just where it's located. And geography is everything. From a surgical standpoint, the rectum is really confined within what we call the bony confines of our pelvis, our hip bones, our pubic bone in front, and our tailbone in the back. Everything kind of it's within its own little box. And so over the last 20 years, we've developed different ways to treat rectal cancer. And as I mentioned, it's treated very different from colon. Colon cancer typically is treated with a surgery first approach. Of course, we go, we have to stage the patient, meaning we have to make sure there isn't spread of disease elsewhere. That's always kind of our first step. Once we delineate that there is none spread of disease, then surgery would usually be the first treatment for colon cancer. When it comes to a rectal cancer, which is the last 15 centimeters of our gut, it depends also on the stage, but typically treated first with what we call chemotherapy and radiation before surgery. And now our advances are to the point where we have such good oncologists, radiation oncologists such as yourself, that some people with rectal cancer don't even need surgery. And it's called watch and wait. And we see these patients who have an excellent response to the chemotherapy and radiation and no longer need a major life-changing surgery.
Right.
So,
And you mentioned when you started talking about the different pillars,
yes.
anal cancer. So anal cancer technically is not colon or rectum, but
Right.
it's similar. It's the very last inch or so of the gut as it passes out of the body, and that's probably for decades we've been doing chemotherapy and radiation without surgery
Mm-hmm.
for the anal cancer.
Yes.
And so some of those principles have kind of moved upstream, if you will, a bit, and we're using them in rectal cancer. Before we talk some more, and I really am interested in having you talk about the newer surgical techniques in terms of robotic surgery and all of the other advances. But let's just do a little bit about risk factors first,
Mm-hmm.
and then how do we screen, and then we'll get into treatment. So what are the primary risk factors for developing colorectal cancer?
I think age is probably the most important risk factor, and that's why we have the screening guidelines in place. Even though we are seeing a shift towards younger patients, majority of patients diagnosed with colorectal cancer are still older, 60 and above. So I would say age is the most important. After that, we have, of course, the genetics. That is a risk factor. So that all comes into play when we decide when a person should get screened and when they should start screening. screening. And typically, we say that if you do have a first degree family member, mother, father, brother, sister, with history of colon cancer, you'd want to be screened at least 10 years before that youngest person was diagnosed. So those are the two major risk factors. And of course, what we had talked about earlier as well still come into play, even with the older population, diet and environmental factors.
Right. And some of the dietary is highly processed foods.
Mhm.
And maybe red meat. People who eat a lot more red meat have a
Mhm.
higher risk of colorectal
Yes.
cancer.
Unfortunately, red meat, and I do like a good barbecue just as much as the next person, but specifically the charcoal kind of grilled on the grill, that type of meat. I think it's more the nitrates that get produced in that process, so that is associated with the higher risk.
Okay, and then obesity and physical
Yes.
activity also
Yes.
play in. So
Yes.
those are some of the risk factors. And in terms of genetic, we might call out Lynch syndrome.
Oh, yes.
And I'm always fond of calling that out because I went to a medical school
Oh,
at
you
Creighton,
were trained by
and
Dr.
Henry
Lynch. Yes.
Dr. Henry Lynch, who discovered or made the association
Mhm.
with a familial pattern of colorectal cancer that now bears his name.
That's right. And that was really a recognition of this constellation of cancers that tended to come together as a cluster. So, certainly colon cancer, colorectal cancer, and associated as well with some gynecologic malignancies. And what that means is when we ask for family history, when I see a patient in my clinic, I'm very interested to know what their family history is. So I will always ask, especially women, do you have mother or sister, aunt with a history of gynecologic uterine cancer, breast cancer, all that would make me think, that I need to dig a little bit deeper here. And then certainly there are some urinary cancers as well that are associated with it.
Okay. So, because colorectal cancer is common and we have developed screening. So,
Mhm.
screening is when you look for a cancer in someone who doesn't have any symptoms.
Right.
And so, what are the screening techniques for colorectal cancer?
They're broadly divided into two categories. So we have our stool-based and blood-based techniques, as well as our procedural-based techniques, I would say. So I'll start with colonoscopy. That's what I did all day today in my work. And colonoscopy is where the patient will take a prep. And I always tell people it's just we have such simple preps these days. It's not the 4 gallons that your grandmother took, when she did her colonoscopy. Very simple, even as simple as Gatorade mixed with Miralax. And I tell people, you drink Miralax every other day or every week or, occasionally, and you drink Gatorade. And so just put those two together and that's your prep. And so I often find that's one thing that is a barrier to people getting colonoscopy. So colonoscopy, where a video attached or a camera attached to a scope, and it snakes its way through the colon, looks at every nook and cranny. If we have polyps, we take those out. And I do think that colon cancer screening is a bit of a misnomer. We're screening for polyps because colon cancer is something that's very preventable, because if we get the polyp before it develops into a cancer, there's no chance for cancer to develop.
Right. So like the screening for breast cancer is a mammogram, but a mammogram might find an early cancer, but it doesn't prevent cancer.
Yes.
Whereas a colonoscopy, not only could you find a cancer, but you remove polyps that if you hadn't removed them might develop into cancer.
Yes.
So the screening for colorectal cancer can actually prevent colorectal cancer.
Yes, yes. And I think that's one of the most rewarding things about doing a colonoscopy. When we do a colonoscopy, we don't want to find cancer. We want to find polyps. And that makes us feel good, because that's okay. This is the point, and this is why we did this. And that's what I tell every single patient when I tell them you have a polyp. It's a good thing that you came in and this is gone, and there's no chance for that to develop into a cancer.
Okay.
So that I would say is the gold standard modality for screening.
And then you mentioned the other acceptable screening is to take a piece of stool
Mhm.
and to look in the stool for either some evidence that there's blood, microscopic blood in the stool, or looking for evidence of DNA from cancer cells,
Yes.
that we actually now have the technology from a piece of feces
Yes.
to actually find DNA from a cancer cell in the
Yes.
stool.
Yes, the advancements that we've seen over the last 10, 20 years have been amazing. And yes, so it's popularly known as the Cologuard test is what we're talking about when we talk about stool-based tests. And it is a great way to screen people who do not have any symptoms because, as you said, Dr. Deming, it detects these particulates of DNA that are shed by either a polyp or a cancer, unfortunately. And people do not have to drive far. And so I really think that has helped with the barrier of distance. There's, so much. So many people who live very far away from access to colonoscopies, and this is a great way to, if it comes back positive, you need a colonoscopy, and I think that is the logical next step, and most people are very willing to pursue that.
So it doesn't require prep.
Right.
If it's negative, you don't have to have a colonoscopy. It's a positive, you do. But on the other side, it doesn't prevent cancer.
Right.
So a colonoscopy not only is screening, but it can actually prevent cancer. Doing the stool-based testing doesn't have the ability to prevent a cancer.
It does not. And we do say colonoscopy is still the better method, but the old adage stands, the best screening is the one that the person and the patient will do. Mm-hmm. And so if the Cologuard is more accessible, then I think that's a reasonable option.
Okay. So now let's get into treatment. And in particular, and you outlined that usually colon cancer is, well, first when we find the cancer, then we stage the cancer to determine what's the extent of the cancer. So cancer obviously begins on the inside of the colon or the rectum. If the cancer were to become more advanced, where are the places that it would most likely go?
So when the cancer itself grows, it grows through each lining of the bowel wall. And the bowel is kind of like a cannoli with 4 layers. You have your innermost layer and then outer layers. And so as it grows through each layer, the lymphatics can get affected, meaning there are highways that carry the blood and your lymph fluid from the colon back to the rest of your body. The most likely place that the cancer will first spread to is usually the liver, because that's the way our traffic works.
So lymph nodes first, and then the liver would be the distant site.
Yes.
So removing lymph nodes is an important part of colorectal surgery.
Yes. And I'm so glad you brought that up. One of the top questions I get asked all the time is, well, why can't you just take out that piece of the bowel that has the cancer in it? And the reason is because when we do surgery for cancer, we want to make sure we do a really good surgery. And what that means is taking the main blood vessel that supplies that area of the bowel, because that's where the lymph nodes lie. And once we take that main blood vessel out, that entire segment of your bowel no longer has blood supply. So we have to take out a pretty sizable chunk when we do the surgery to make sure that what we leave behind has good blood supply.
And then reconnect everything.
Yes, we hook the pipes back together.
Yes. So we've diagnosed the cancer, we've done the staging and determined that the cancer has not metastasized to the liver or any other place in the body. So let's talk about colon cancer. And as you mentioned, surgery is usually done first. What are some of the techniques, the standard techniques, and maybe what are some of the newer techniques for surgery for the colon?
hmm So, when we talk about surgery for the colon, I would say the procedure itself, the surgical, the operative steps itself have not changed much over the last several decades. And the reason for that is because there was a very standard approach to doing colon surgery. Basically, the idea is to get into the belly, and we go through any scar tissue. For people who've had surgery before, they might have some scar tissue, just like when you cut your hand on a branch or something like that. We go through that, we find the area that we're concerned with, and then we so-called mobilize, meaning we detach the colon from the rest of the things that we were made attached to. After that, we take that part out along with that main blood vessel, and then we hook things back together. So that is the actual operative surgery that we do. The approaches are different and varied. And so they range anywhere from laparoscopic, which is small, tiny little incisions, and then robotic, which is also small, tiny incisions, to good old fashioned open surgery, where we made a large incision and take the colon out that way. So those are the different approaches.
And what are the pros and cons of those various approaches?
So I think the surgeon or the patient and their anatomy, as well as the disease process, will dictate which approach will serve that person best, and we take that into consideration. When I see a patient, I will take a look at everything from how many surgeries they've had in the past to medical problems, things like that. The pros of, we'll talk about the minimally invasive, so the robotic and laparoscopic approach, are that they're small incisions. So usually the bigger the cut, the more the pain, because it's a bigger incision. And so those modalities give us a way to look at things, magnify. The robot can magnify things tenfold. So they give us very good field of vision. And we're able to do the same surgery with much smaller incisions and scars.
And much faster recovery time for the patient.
Yes, because you're not. I tell people we're not messing things around, and we're not flipping things back and forth as much as open surgery.
And cutting through as many muscles.
Yes.
Yeah.
Yes.
So that's the colon. And then what are some of the techniques for rectal cancer surgery? And you already mentioned some of the special factors, that it's really deep down in a bony pelvis. You don't have the ability to access it as well. So what are some of the standard and newer techniques for doing rectal cancer surgery?
The standard technique for rectal cancer surgery, or the standard operation, is what we call a total mesorectal excision. And what that means is your rectum is surrounded by this envelope of blood supply and lymph nodes. And that's what we call the mesorectum. And the idea is to take out not just the rectum, but that mesorectum, which is it blankets your rectum, so to speak, and take that entire area out intact without violating anything inside. And that's really what everyone strives for when we do a good rectal cancer surgery. Some of the newer options that are coming out are actually taking the rectum out from the bottom. And so there's an operating platform that you put through the bottom, and for smaller cancers, you can just put it right through the bottom opening, and you use laparoscopic gas to insufflate your bottom, almost like doing a colonoscopy, and you insufflate everything from below, and then you can cut that cancer out, and that's acceptable for very, very early stage cancers.
Okay. And that is without the need to remove the anus.
Yes.
So you can
Yes.
go up through the anus.
Yes, correct.
Internally.
Yes.
Remove part of the rectum.
Yes.
Reconnect.
Mhm.
And then withdraw.
Yep. You could suture that inner lining back
Okay.
together. And then there's also what we call a transanal TME, which is an approach from the bottom, where it is actually taking everything out, that entire rectum and the mesorectum, and work with both a bottom down or bottom up and top down approach, usually with two surgeons operating at the same
Gotcha.
time. And then we meet in the middle. We call that the colorectal handshake, where we meet in the middle and then
And
we take
reconnect.
yep, and then take the specimen out.
Okay. And I keep emphasizing reconnect because in colon cancer, patients usually, it'd be rare to need a colostomy. Sometimes a temporary colostomy,
Yes.
but when you get down to the rectum, sometimes you have to remove it's such a low portion of the rectum that you really can't reconnect. So you have to remove the anus, and a person has a permanent colostomy.
Yes.
So talk a little bit more about in what circumstances in rectal cancer does the surgery allow you to reconnect so that a person still has bowel movements that come through the anus, and when do you have to remove the anus and then the bowel movements come through a colostomy into the bag on their abdomen?
Yep. It's all about the last few centimeters, as we say, and each centimeter matters so much. The rule of thumb is the closer we get to the anal opening, the less likely we'll be able to connect. And the reason is because if a tumor invades the muscles that surround the anus, we would not be able to save that typically. And if we were to cut that out, there would be really nothing to hook back up to. In addition to that, I think that would be pretty difficult for the person in terms of control and continence. Our muscles down there are very important to control things and give us that voluntary continence to hold everything in when we're in public and then release when we're able to find a restroom. So I think that's the biggest determinant is distance to anal opening, as well as the size of the mass, the tumor. When we talk about a permanent bag, and I think that's one thing that most people come very, very concerned about, the need for a permanent bag. I would say that we try very hard not to give someone a permanent bag. It is a big change in your lifestyle and your function. And the only times we would do that is if that absolutely were the only safe option from a cancer standpoint. And at that point, cancer takes precedence over that for most people.
Right.
Yep.
And you mentioned that in cancer of the colon, the upper large bowel, surgery is usually first, and then depending on how big the tumor was, how deeply it invaded, and whether lymph nodes were involved, determines whether after surgery a patient might need chemotherapy or not.
Yes. Yes. After we take the specimen out, we're sending that completely intact to our pathologists. And our pathologists are people who study the cells and what we call the histology, how things look under a microscope. And they will take a look at what we've sent them and determine whether or not the lymph nodes were affected by cancer. I typically will refer most people to see an oncologist to get their opinion on what the next step should be. And it's really a team effort. We're very, very lucky to have great working relationships with our oncologists and radiation oncologists here.
And in the rectal cancer, as you mentioned, instead of surgery first, it's more common now that we would do the chemotherapy and radiation therapy first.
Yes.
And that's been a real change over the past few decades because it used to be just like the colon, surgery goes first, and then you decide whether to add in the radiation or chemo afterwards.
Yes.
And now we've seen such good response, the tumor response to the chemotherapy and radiation, that sometimes we can make it almost appear to go away.
Yes.
And then follow up with the surgery. And I would say another thing that we're seeing is maybe we can skip the surgery. But in patients who need the surgery, maybe we can skip the radiation.
Yes.
So that's, just in the last year, that study was done. Instead of giving everybody chemo and radiation up front, some of the patients might be able to skip the radiation. And then, as you mentioned, some patient might be able to skip the surgery. So we're always looking at how can we cure the patient, but also how can we do it in a way that allows the best function
Yes.
with fewer side effects.
Yes, I think it's all about getting someone through this unfortunate event, but back to their normal, their new normal, as fast as we can. So,
What are some of the other developments in colorectal cancer that, and I'm thinking maybe to talk a little bit about somebody who might have cancer that spread to the liver, but that it's fairly limited, and maybe also talk about maybe circulating tumor DNA and the role that that might play in monitoring patients who have cancer.
yes, the circulating tumor DNA, the ctDNA as we call it, has been very exciting new technology that we have where we monitor the patient's blood and we can actually monitor whether or not, mostly for patients who've had a cancer, who've had treatment, whether or not that's been a recurrence. And I think that's really exciting that we've been using more and more here.
Right.
Yeah.
So we talked about the science that in screening, you can
Yes.
take a piece of stool, feces, and
Yes.
look for tumor DNA as a screening technique. But in individuals who have a history of cancer, you actually can do a blood test to
Yes.
see, are there pieces of cancer DNA in the bloodstream, which would imply that it's somewhere in the body.
Yes. Yeah. But it's been being used more and more now.
Okay.
So, yeah.
And what about patients who, so traditionally we would say, oh gosh, if it's in the liver, it's incurable. I think we're learning now that there are some patients with colon cancer who might have a small amount of cancer in the liver, and we
Yes.
might incorporate removing part of the liver as overall treatment.
Yes, we work very closely with our surgical oncologists who are our liver surgeons, and we have so many different options for our patients. And what that means for the audience as a whole is just because you have everyone's always wanting to know what stage, and typically it's just very disheartening when you learn that, oh, I'm stage 4. But we have so many options now that we are being very aggressive with the treatment and treatment for cure, even for patients who are diagnosed with stage 4 disease. So it's no longer as bad of a sentence as it used to be for patients. Some of the options are a surgery to remove part of the liver. And a lot of times we do chemotherapy first to try to shrink those lesions so that they become something that we can take out with surgery.
Unfortunately, colorectal cancer is a cancer that tends to respond quite well
Yes.
to chemotherapy.
Yes. One of the reasons I went into colorectal surgery was that most people actually do very well with surgery and chemotherapy, and they do go on to, again, their new normal, but very fulfilling, lot of life left.
Yeah.
So.
Um, let's switch just a little bit before we open up to questions. I'm
Mhm.
interested in some of the surgeries that you do as a colorectal surgeon,
Yes.
a very subspecialized surgeon, that aren't related to cancer. And you mentioned some of the pelvic floor.
Yes.
So things related to incontinence of stool.
Yes.
So individuals who, and we'll have you discuss, can't seem to control it,
Mhm.
or patients who have such severe constipation that maybe they need a surgical. So maybe touch a little bit on that deep pelvic floor that's not related to
Yes.
cancer, and what are some of the surgeries that you do that help people and improve their quality of life who might have issues related to defecation.
Yes, thanks for asking, Dr. Deming. I think it's a very important topic. It affects many, many people, and oftentimes a lot of embarrassment surrounds that topic. But, I don't think there's anything embarrassing at all. Many, specifically women who've had many children, that affects your pelvic floor. And, I have 2 children myself and went through that. And so incontinence is where after having children, for example, you are unable to control that stool as well as you were when you were 20 years old. And that all has to do with the pelvic floor musculature. We do have great options for people now. I always tell people, everyone is familiar with pacemaker for your heart. We have pacemaker for your bottom, is what I call it. It's a little implant that goes into your back, kind of low back, and it controls and sends signals to that nerve that controls the continence. And, I recently put one in for a patient of mine, and she said for the first time in 20 years, she was able to go on a road trip more than 5 minutes away from her house.
Wow.
And it was completely life-changing.
So it sends an electrical stimulation that causes the muscles to contract, that keep the opening closed. So when a person who has that wants to have a bowel movement, do they turn it off?
No. The way it works is it stimulates that sacral nerve, and it's not a mechanical stimulation.
Okay.
And it relays signals to the brain as well, and allows you to have continence and
Okay.
control. And so it's a wonderful device that has brought a lot of relief to many of patients I treat. And going hand in hand with that, also anal rectal, it's one of the pillars of colorectal surgery. So anything from hemorrhoids to abscesses and fistulas, those affect so much of the population. And, I think malignancy cancer is very important, but so are the other benign, non-malignant conditions that affect people in their day-to-day lives. And that's a big part of my practice as well.
Okay. Well, I'm going to spare you the question about the potty squatty or the squatty potty, and we're going to open it up to questions. So we've got a live studio audience here. They get the first questions. If you are watching us live streaming, you can put your questions in the comment section. So first off, Poon.
What symptoms can people expect? Because you said it's like colon cancer is at an earlier age. For colon cancer and rectal cancer, is there symptoms?
Yes, there are symptoms that are associated. Typically, we ask for rectal bleeding. So any bleeding that appears, changes in your bowel habits, meaning you typically were a very regular person. First thing in the morning after your coffee, you have a bowel movement, you move on with your day. And that's changed recently. So that would be something we'd want to know about, as well as the change in how your stools look. Sometimes stools can get more thin. We call them ribbon-like, where they're a lot smaller than usual and thinner. That would be something that we'd want to know about as well.
Hi.
Hi.
Let's talk a little bit more about screening. Okay, so you mentioned the screening of colon cancer, for instance, is going downward to 45 and whatever. Let's say I had a colonoscopy at 55, right? And they removed a bunch of polyps. When's the next time I should have a colonoscopy?
That's a great question. It depends on the type of polyp you had, as well as the number. And there are pretty good guidelines that everyone in the United States follows. And so some types of polyps are more concerning than others. And if you have more of those type of polyps, we would want you to get screened your next surveillance a little sooner. Usually the intervals are 3 years, 5 years, 7 years, and 10 years, depending on the number, size, and type of polyp you've had.
So if you have a colonoscopy and it's spick and span clean, you can go 10 years.
Yes, if it was a really good prep, we could see every nook and cranny, then yes, you would be good for 10 years.
And then depending on what type of polyp and how many you have, you may get called back to do it more frequently.
Yes.
Okay, great. Other questions? Yes, George.
This question's about the colonoscopy itself. Is there a situation sometimes where the colon is so circuitous, where you can't get a good look, where you can't get through, where it's just not an option, where it doesn't work?
Yes, we have encountered some twisty, turny colons. And typically, we have a lot of different maneuvers that we try during the procedure. We'll spin you around, put you on your left side, right side, to try to move that colon around our scope. So we do a little bit of creative gymnastics sometimes during the procedure, having someone put some pressure on to help the scope go through. Ultimately, there are definitely times where even the best person who does colonoscopies can't get through all the way. In those instances, we'll either have someone else try again, maybe with a different type of scope, or there is something called a CT colonography where you do prep and they put something up your bottom, and then it's a CT scan that takes images of your entire colon. So those are the options that we go with.
Is a Cologuard test an option for somebody like that? I mean, to revert to that?
So if it was for screening, I think it could be an option. Typically, that's not what we would do, though. We'd go either with a CT colonography or another attempt.
And if this Cologuard is positive, though, then you got to look.
Yeah, you still need to look
at that point,
Yeah.
or a patient is symptomatic. What about the colonoscopy itself? So I've heard that some docs that do colonoscopy are willing to do it without any anesthesia, conscious sedation, or medication at all. What would you say, what's your preferred on a healthy person who, isn't afraid of a little bit of discomfort?
I think sedation is definitely helpful because it just relaxes your body and also your abdominal wall muscles. I can't imagine it'd be very comfortable to be completely awake for that procedure. Yes, I think there are. I don't think I've ever done a procedure without sedation. Everyone I've done a procedure on has wanted the sedation. I would take the sedation, but I don't think would be harm if they didn't want, if someone doesn't want to receive that type of medication, for example. We can certainly try without it, but
and usually sedation is intravenous.
Yes.
And is that done with an anesthesiologist or without an anesthesiologist?
It can be done with or without. I usually do my own sedations, and I'm trained on that. And so it's just medicine through the IV that gets you nice and sleepy. One of the medicines is also amnestic, meaning you don't remember anything. So I've had whole conversations with people when we're doing the procedure, and then they wake up and the first thing they ask me is, "Did you do the procedure? I don't remember a thing." And that's exactly what we want.
Okay.
So you don't remember much.
Very good.
And I'm curious about the cancer spread to the colon and from the colon. How does cancer spread from the colon? I thought the colon was on the way out, as an example. So can cancer spread from your colon to other parts of the body? And which is more common, spreading from the colon or cancer spreading to the colon?
More common for a colon cancer to be what we call the primary. So that was the main cancer that spreads elsewhere in the body. And it spreads by the lymph nodes, which are on your blood vessels. And so that's how the cancer spreads from the colon to other organs in the body.
As I understand it, not all colonoscopies are equal. I mean, some are done better than other ones, and you're graded. Are those the patients have access to, like a doctor's grade level?
That's a great comment. Yes, that's true. Much of colonoscopy is what we call operator dependent, meaning it does depend on the person who does it. There are grades and report cards that every person who does colonoscopies gets. And the biggest indicator of a good quality colonoscopy is usually what we call your adenoma detection rate, meaning they look at every single person's rate of polyps that we've detected. So they'll pull up my procedures and say, this person did these number of colonoscopies and they found this number of polyps. And the hospital, I don't know that the population, general population has access to that, but the hospital does go through and grades every person on how good their scope is and their quality of scopes. And if it's not up to snuff, then some retraining might be needed.
I've heard that the United States is a hotbed for colon issues and colon cancers compared to other parts of the world. Is that true? For instance, I've heard that colon cancer is much less prevalent in Europe than it is here. Is that true?
I think it depends on what part of the world we're talking about. In general, though, the United States does seem to have a higher rate of colorectal cancer. Much of that, again, is linked to diet and lifestyle.
How can a sedentary lifestyle affect the colon?
I think when they say sedentary lifestyle, that points more towards obesity and having some excess weight. And it is thought that obesity is a inflammatory condition, meaning things are very inflamed within the body. And that's one of the things that will increase the risk of cancer due to that constant inflammatory state in the body.
Last question for me. I've got a couple of family members and I've got a couple of friends that have had large amounts of their colon removed, like 18 inches. Is there a safe zone, or is there a amount of colon that is extraneous that can be removed?
So you can actually live pretty well without your colon. Some people have their entire colons removed. It's one of the more forgiving organs, meaning your life certainly is changed without it, but you can certainly still go on to have a good quality of life without the colon.
We have time for one more question. Do we have any from the online community? No? Yes. Last question, Kevin.
How much colon do I have, feet-wise?
You have, what's the number?
3 feet?
I'm not good with feet measurements.
A meter?
I like to measure in centimeters because that's what my colonoscopy shows me. Most people have about 80 centimeters of colon. Yeah. And how many feet is that?
Well, 80 centimeters, so it's 2.54 inches per centimeter.
I need my Google.
Right.
My
So I
calculator.
was always thinking it was 3 feet, which is like a meter stick is almost
About-
like a yard
about 3
stick.
feet, yeah. So.
We'll get back to you on the exact amount. I'm sure there's some variability.
There is, yeah.
Yeah. Yeah, it's not 10 feet.
Everyone's
But
a
it's
little
about,
different.
what's your
At 2.6.
answer? How much, if you do small intestine and large intestine, how many?
Small
feet?
intestines is probably about 200 some centimeters. So plus the
So that's
70,
about
so
6 feet.
300 centimeters or so.
Yeah,
It's
a lot. I thought
Did
we
someone
had
look
about-
up on Google?
How
Perfect.
How many centimeters?
Usually the colon's about 70 to 80 centimeters.
Okay, 80 centimeters is 2.6 feet.
Okay. So you're right, about 3 feet. Yeah. Give or take.
Well, Dr. Mayin, thank you so much. Colorectal surgeon at MercyOne Cancer Center. Thank you for being our guest. If you know someone that would benefit by watching this segment tonight, it will be available tomorrow on demand at the Above and Beyond Cancer YouTube channel and the MercyOne Cancer Center website. And I hope you'll join us again next week for our cancer education series. Thanks, everyone.